Now we will talk about nasal polyposis. This is an end-stage local manifestation of chronic inflammatory disease of sinonasal tract. Nasal polyps are hypertrophied, edematous, pedunculated nasal mucosa prolapsing out of the nasal cavity or paranasal sinuses. So these are benign, hypertrophied, edematous, and pedunculated mucosa of nasal cavity. So the most common sites or origin of these polyps are ethmoid air cells, maxillary antrum, or sphenoid sinus. So if they are originating from ethmoid air cells, we can have ethmoidal polyp. If it is from axillary sinus, generally it is unilateral, so commonly it's known as anthropoanal polyp. The pathogenesis commonly known or idiopathogenesis for the formation of polyp, there are many theories, one of which and most accepted theory is bacterial infection or allergen exposure or superantigen exposure leads to activation of mast cells, macrophages, and epithelial cells. This causes release of inflammatory medias, inflammation of sinonasal tract followed by edema. Rupture and herniation of edematous stromal tissue leads to formation of polyp. This is how a polyp is formed. There are various number of theories, but most commonly accepted theory is this. Histologically, they consist of loose connective tissue, inflammatory cells, and fluid. They are lined by pseudo-stratified ciliated columnar epithelium. In long-standing cases, the epithelium may undergo squamous metaplasia. It's a characteristic by robust T helper cell 2 response, decreased T regulatory function, eosinophilic infiltration, and abundance of interleukin 5. So, there are eosinophils, there are macrophages, there are T helper cells in the matrix. So, these all are the cause for the formation of polyp. Histologically, there are two types of polyp. First is neutrophilic type, seen with purulent secretion and is associated with Cattinger syndrome or cystic fibrosis. Eosinophilic type, it is seen with serous type of secretion associated with asthma, allergy, and also with aspirin intolerance. The associated diseases, that are the diseases which can have which can have polyp in their nasal cavity. Those are asthma, allergic fungal rhinosinusitis, cystic fibrosis, primary ciliary dyskinesia, Young syndrome, Suck-Strauss syndrome, and aspirin exacerbated respiratory disease. There are in general two types of polyps. First is ethmoidal polyp. The second is enteroconal polyp. Now we will discuss ethmoidal polyp. Ethmoidal polyps are the polyps that originates from ethmoid air cells. As we know, there are multiple ethmoid air cells, generally anterior ethmoid air cells. So they are multiple in number. So ethmoidal polyp arise from multiple air cells of ethmoid labyrinth, multiple grape-like masses which can be seen on anterior rhinoscopy. The common sites are uncinate process, bulla, ethmoidalis, medial surface of the middle turbinate. So, as I have told you, most commonly anterior ethmoids are involved. So, the anterior ethmoids are present in middle meatus. They open in the middle meatus, as I have told you in the anatomy of the nose class. So, maximum number of polyps, they originate from ethmoid air cell and they open in middle meatus. So, there are multiple grape-like structure originating from ethmoid air cells, and they are present in middle meatus in most commonly. Now, the etiological factors for ethmoidal polyp are hereditary. The cause is that Bernoulli phenomena is seen because passage of air from a narrowing site causes prolapse of the mucosa into the cavity. When this increases, the size of the polyp too increases. Allergy, infection, vasomotor response, polysaccharide metabolism disorder, vasomotor response, uh, polysaccharide metabolism, endocrine, and polypeptide theory. These all are the etiological factors or suspected etiological factors for formation of polyp in a patient. Like allergy causes edema, the pathogenesis which I have just told you is typical allergy and infection type. In polysaccharide metabolism disorder, it occurs that the polysaccharide which hold the basement membrane to the submucosa is absent or they are deficient. So the edema causes separation of the epithelium and submucosa leading to formation of a matrix in between the layers and ultimately formation of the polyp. The symptoms of a nasal polyps are nasal obstruction, nasal discharge, hyposmia or anosmia, headache, broadening of the nose on long standing cases. So there is widening of this dorsum of the nose. It is also known as frog nose like appearance is there. On the signs, that is the finding on examination of the nose, we get on anterior rhinoscopic examination, we there is a polyp appearance. The uh, characteristics of the polyp are so the characteristics of a polyp are the smooth, glistening, grape-like mass, pale in color. They can be sessile, can be pedunculated, multiple bilateral, insensitive to probing, and they do not touch on bleed. Broadening of the nose, increased intercanthal distance, sign of nasal allergy may be present, cold spatula test, reduced or absence of the fogging because of obstruction of the nose. So, what are the differential diagnoses for ethmoidal polyp? Congenital conditions like malingocele, encephalocele, hypertrophic inferior turbinate, granulomatous polyps like in case of rhinosporidosis, rhinoscleroma, TB, malignant polyp like inverted papilloma and angiofibroma are the differential diagnosis of the ethmoidal polyp. Now, what all investigation we will do? Diagnostic nasal endoscopy. In radiology, we will go for X-ray PNS. We will go for CT-PNS. CT-PNS showing specific comment on osteomeatal complex. As I have told you, the origin is from middle meatus and osteomeatal complex is present in middle meatus. So, special acknowledgement should be given to osteometal complex. Allergic test including skin prick test, nasal swab for fungal culture and biopsy of the pollen. Management. Conservative management consists of the medical management, that is controlling the allergy by giving antihistaminic and stopping the exposure of the allergen. Second, short course of steroid is given in patient who cannot tolerate antihistaminics or uh, with asthma, those people who cannot go for surgery, short course of steroid act as surgery only. The size of the polyp is drastically reduced. It is also known as medical polypectomy, or then the definitive treatment is surgical, that is simple polypectomy, or if we polyp is larger in size and we need to go for Cadwell operation for recurrent polyps, and the best surgery for the polyp is FES, that is functional endoscopic sinus surgery. Now the second type of the polyp is antroconal polyp. So the second type is the antroconal polyp. It is also known as Killian's polyp, commonly seen in children, originates from maxillary sinus. So it is solitary, not multiple, only single. It protrudes in the middle meatus. It further extends posteriorly into the nasopharynx. So it has three parts. First part is the antral part, which is present in the maxillary antrum. The second part is the nasal part, which is present in the nasal cavity. And the third is the choanal part, which is present in nasopharynx. So antral part is the side origin is small in the maxillary sinus. The second part in the nasal cavity is compressed bilaterally, and the choanal part is globular. It is round in shape as it is present in nasopharynx. So the symptoms for enterochoanal polyp is unilateral nasal obstruction. As I have told you, it is generally unilateral and single in number. So unilateral nasal obstruction, nasal discharge, post-nasal drip, and headache. The signs on posterior rhinoscopy, as I've told you, there is a choanal part. The choanal part is generally present in the nasopharynx. So on posterior rhinoscopy, pale translucent choanal mass may be present. Sometimes it comes out of oropharynx, pushing the soft palate downward. So here in this diagram, we can see a pale mass coming from the nasopharynx over the right side, pushing the soft palate anteriorly. This globular mass is the choanal part of the antrochoanal polyp. What are the differential diagnosis of antrochoanal polyp? Unilateral nasal mass are the differential diagnosis, common point of differential diagnosis of enteroconal polyp. So they are juvenile nasopharyngeal angiofibroma, meningocoel, hematoma, hypertrophic posterior end of turbinate, sphenocoinal polyp, and nasopharyngeal rhinospheroidesis. These all conditions are differential diagnosis of enteroconal polyp. What are investigation are need to be done? Diagnostic nasal endoscopy followed by radiological examination. In radiological examination, we will go for X-ray PNS followed by X-ray soft tissue neck lateral view. In soft tissue neck lateral view, we will get a crescent sign. What is meant by crescent sign is there will be a crescent of air present in between the posterior pharyngeal wall and the polyp. We can see a column of air in the shape of a sickle or a crescent in between the polyp and the posterior pharyngeal wall. So we can suggest that this is a enteroconal polyp, not adenoids, as adenoids originate from the posterior or posterior superior nasopharyngeal wall. This air column will not be there. So this is to differentiate between the adenoids and the enteroconal polyp, or you can differentiate between nasopharyngeal carcinoma from enteroconal polyp by a crescent sign. Similarly, as ethmoidal polyp, we will go for CTPNS. As I've told you, the origin of this polyp is from maxillary sinus. So, osteometal complex is a place where there is an opening for maxillary sinus. So, special report on the comments on the osteometal complex is also required in CTPNS. Now, what are the line of management? As I've told you in previous management of the ethmoidal polyp, there is chances of recurrence. But in enteroconal polyp, recurrence are very rare as compared to ethmoidal polyp. So, antibiotic, polypectomy. Polypectomy is not done nowadays. We will go for functional endoscopic sinus surgery. This surgery is preferred over all the surgeries as it preserves the functional mucosa of nasal cavity. So, functional endoscopic sinus surgery. In cases of revision, the person is operated and the operation done is Cadwell lock operation. So, what is the main difference between the two? Between the ethmoidal polyp and enteroconal polyp. First, the age. The ethmoidal polyp is commonly seen in adults. Enteroconal polyp is commonly seen in children. The etiological factor for ethmoidal polyp is allergy or it can be multifactorial like polypeptide theory or it can be polysaccharide deficiency. There are n number of theories, so there are multifocal theories for the ethmoidal polyp. For enterogonal polyp, it is most commonly infection and chronic irritation of the maxillary sinus, ostium, or mucosa. Then number ethmoidal polyp are multiple in number as there are n number of ethmoid hair cells. But enteroconal polyp as it originates from single maxillary sinus, so it is solitary. Now, ethmoidal polyps are present bilaterally, but enteroconal polyp is usually present or is present unilaterally only. Origin ethmoidal polyp, as the name suggests, is from ethmoid hair cells. Enteroconal polyp, it is usually originates from maxillary sinus near the maxillary ostium. Now the growth, the as I've told you, anterior ethmoid hair cells are most commonly involved in ethmoidal polyp. So the polyp grows mostly anteriorly and can be examined easily from anterior end or during anterior rhinoscopy. In enteroconal polyp, the polyp grows backward towards the cornea and may hang down from the nasopharynx, pushing the soft palate anteriorly. So, usually early visible on posterior rhinoscopy or can be seen on diagnostic nasal endoscopy. And when the polyp is enlarged, you can see it on the anterior rhinoscopy too. Now, shape and size in ethmoidal polyp, there are multiple small grape-like appearance. In enteroconal polyp, it is a trilobed structure, which is the antral part, nasal part, and a choanal part. I have told you the small antral part, uh, mediolaterally compressed nasal part, and a globular choanal part. Recurrence. Recurrence is very common in ethmoidal polyp and enteroconal polyp. The recurrence is very less if removed completely. If some part of the polyp is remaining, we can have recurrence in enteroconal polyp too. Now the treatment in cases of ethmoidal polyp, we can have a short course of steroid therapy that will act as a medical polypectomy of the ethmoidal polyp. And For enterocorneal polyp, functional endoscopic sinus surgery is best line of treatment. Also, for ethmoidal polyp, we can also go for functional endoscopic sinus surgery. That was all for nasal polyposis. Thank you, all of you.